We'll be talking about a team-based approach today. So what that really is just the components of a successful practice for medication for opioid use disorder. And I do want to say this is Dr. Bott's presentation. I'm filling in for today because he couldn't be here. And I do have the sort of ground level view on the team-based approach. I've been in several clinics where this was the model, or it was an iteration of this model. But if you have any really clever questions that would benefit from Dr. Bott's kind of eye in the sky view on a team-based approach, I'm very happy to pass those along to him so you can benefit from his expertise. So in terms of our objectives today, we'll be describing the importance of using a team-based approach. So why are we spending a presentation on this? How is it relevant to you and your potential to practice with it? We'll identify the team members that are recommended for an office-based buprenorphine program and describe the roles and the responsibilities of each team member, because a big part of this model is making sure that everybody kind of has their right place so that they can practice at the highest level of their skill pyramid and make sure they're providing the best care possible as efficiently as possible. And then we'll wrap up with talking about how your administration can support building a team based on this model if they're open to it. So as a sort of a preface before we get into the details, the whole idea of the team-based approach is really leveraging resources. It's about how can we do a lot with a little? And I know we're really good at that here in New Mexico. We've had to become really good at figuring out how to serve as many patients as possible, relying on relatively few providers. And so what this model is really about is making sure that we're sort of optimizing the team to make sure that patients are getting the best care that they can, quality, comprehensive care, and also that staff is not overextended, that staff isn't getting burnt out, because that's a really key part of the equation, that both the patients and the staff are happy. So in terms of the sort of semantics on treatment teams, we do know that integrated treatment, so multiple service providers working together, that is considered the gold standard by really all of the regulatory and research bodies that work with this population. So it's a research proven model of treatment for people with all kinds of chronic illnesses, and in this case, people with serious mental illnesses and co-occurring substance use disorders. So one of the reasons that integrated treatment is so successful is that it allows clients to receive combined treatment for their substance use and other forms of mental illness, as well as their psychosocial needs, ideally from one treatment team who meets regularly for care coordination and are able to convey a consistent, cohesive message about treatment and recovery. We know that for individuals in this population who already are very often burdened with a high number of psychosocial stressors, if they have to, in order to get their treatment needs met, go to a bunch of different agencies and work with a bunch of different providers and sort of fragment their recovery in that way, that they're much less likely to adhere to the treatment recommendations to engage effectively in treatment and to establish a positive and sustainable recovery long term. So we're really looking to try to make sure that the one treatment team can address as many needs as possible as effectively as possible. A piece here that sounds semantic, but is an important distinction, is that people often use the terms multidisciplinary and interdisciplinary interchangeably, but there is a difference that's important here. So multidisciplinary means that it's lots of different disciplines that are sort of working together in the sense that they're alongside one another, but they're kind of all focusing on a different piece of the pie. With interdisciplinary teams, as the name suggests, is truly interpolated. So each discipline is bringing their perspective and their ideas to the table together, and the team as a whole is formulating that treatment plan and implementing it together. So that cohesion and just the interpolation of all the different team members is really key here to make sure that patients are getting the care they need and that staff are supporting each other effectively. Some important concepts for the treatment team to all be on the same page about is first, that recovery is more than simply symptom remission or stabilization. Not that that is simple in itself, but recovery is sometimes talked about in these black and white terms of, is somebody abstinent or are they not? And realistically, recovery involves a much bigger picture shift. It involves the development of new meaning and purpose in one's life. SAMHSA refers to hope as the cornerstone of recovery, and I think that's an important piece of remembering just how voluminous, how multidimensional recovery can be and how individual it is for each person. Another point for treatment teams are making sure that we're including all of the people who work with a patient, not only the providers, but their support system, and then most crucially, the patients themselves. And that goes to the third point, which is if the patient does not have ownership of the treatment plan as it's developed by the team, there's substantially less likelihood that they're going to do the work that's directed by the plan and by extension to get better, as the treatment plan indicates. So there's a phrase that Dr. Bott uses that I think he borrowed from a patient, which is, the patient should be the captain of the ship when it comes to the treatment plan. They're ultimately the ones who decides if the ship is going to be able to move forward and in the trajectory that's been planned. And if they don't have that sense of ownership, the buy-in that comes with co-developing the treatment plan, they're obviously much less likely to get on board, so to speak. So in order for all of these pieces to fit together and to work effectively, it's important from an administrative perspective that an infrastructure is in place in order to promote team cohesion and to allow the team to focus on clinical work. Something you'll notice as we go through the model in this presentation is that what we see in the literature in terms of providers feeling like they're not able to give the care that they want to, the clinical care, is that often their time is taken up with red tape, bureaucracy, documentation, sort of little odds and ends that really are not about the specialty training that they've received. And so a big part of this team concept is making sure that those kind of miscellaneous pieces of treatment that don't necessarily have to go with one particular provider can be assigned to one role where that's all taken care of so that the rest of the providers can focus on the care that they are uniquely qualified to give. So that means providers who are able to see a lot more patients and who are a lot happier about doing it because they have less of that kind of logistics to have to wade into. And then lastly, on this point, there is the expectation that treatment teams use the treatment plan as the bedrock of treatment. Sometimes it gets relegated to kind of a checklist item at the beginning of treatment. But in order for this model to work, it's really important that the treatment plan is that fundamental underpinning for all the clinical encounters and interventions, that all the team members are returning to it consistently, to update it, to refer to it, and to make sure that it's adjusted as necessary or as indicated by the patient's progress. So in terms of the components of a successful team, let's talk about structure first. And the model here is really kind of a hub and spoke picture. There's the core with the patient really right at the nucleus. And then around the patient, there's the primary providers who work most regularly with the patient. Sometimes if there's a concerned significant other in the support system who's very, very intensively involved in treatment, they would be considered part of the core team. And then beyond that, there's a constellation of providers and of social support figures that comprise the extended team. So that includes service providers who do work with the patient, but not necessarily on a very regular basis. So an example that I think of often here is a dentist. I know for a lot of my patients in this population, there are really extensive concerns about dental health, and it impacts their confidence. By extension, it impacts their recovery. So it can be really helpful when in the clinic we can liaise with their dental provider, make sure that they have all the information they need, that the patient is okay with us sharing, that will allow that provider to give them the best care that supports their recovery and understand the whole picture of this patient's treatment plan. In terms of the structure of the team, we do need to have a team leader, a manager that's responsible for the treatment plan and for the team as a whole. And that often, they're not always is the primary person working directly with the patient. We'll talk more about that in a moment. Then there's also a coordinator, a recovery coach who's responsible for organizing the team meetings, facilitating communication, making sure that all the documents and information is tracked and recorded in the treatment plan. So that's what I referred to earlier. This is this key person who's making sure that all the other providers get to focus on the care that they're specially trained to do. And this person is making sure that all of those kind of miscellaneous pieces of treatment, which are important but difficult to track, are all consolidated in one place. A piece of making this model work, and I think this will make sense as we dive into the details, is that it's important simultaneously for people to have a well-defined role on the team so that they know where to concentrate their energy and they're making sure that they're providing the care that they're uniquely qualified to give, but also to have a bit of flexibility so that in cases where, as is almost invariably the case in most clinics, there will often be a time where a provider is out sick or otherwise, not able to provide care right in that moment. And in those cases, it's very helpful when a member of the team in an adjacent role can just briefly step over into that position in order to keep treatment moving forward. So we know that that kind of balance between flexibility within definition is an important piece of making sure that the treatment plan moves forward smoothly with the patient along with it. In terms of the team leader, the program manager, this could be a variety of professions. The key defining aspect is that they're a consistent point of contact for patients and that they're able to effectively coordinate communication both between team members and then also between the team and the patient. So they're that critical interface. They may also have some patient care functions, including conducting support or education groups for the program itself. We'll talk more about this in a moment, but the role that has been most frequently studied in this capacity is nurses, and they have done spectacularly in the research that has been done here. In terms of the recovery coach or the engagement specialist, again, this could be a variety of professions. It is important that they receive specialized training to step into this role because there isn't any kind of profession that hits the ground running here. It's a very multifaceted role. And the overarching pieces here are making sure that this person is expanding services and is providing patient education and psychosocial support. So that can look different with each clinic and with each patient, but generally administrative duties might include things like covering prior auths and checking PNPs, prescription monitoring programs. On the clinical duty side, maybe urine drug screens, administering rating scales, I'll say with the patient education dimension, this is a piece where I really see peer specialists absolutely shine. I think they're in a unique position to be able to provide information about things like the basics of buprenorphine. So obviously not the medical components, but the kind of big picture components. And then also the program expectations and requirements, and particularly harm reduction in language and in terms that are palatable and well accepted by patients and that reflect the context of their psychosocial situations more accurately than conventional health care providers usually can. In terms of psychosocial support, this person in this role is checking in with the patients, they're offering support, and alongside the other team members, they're making necessary referrals. And referrals are an important part of this model because we do know, of course, most clinics are not going to be able to provide everything under one roof. It would be great if we could, but that's quite rare. And we know that this population, for example, with the original study that we'll get to in a moment, the population was all patients at community healthcare centers and federally qualified healthcare centers. And we know generally with that population, particularly with patients seeking MOUD, there are a lot of negative social determinants of health, so that they tend to have a high utilization rate of emergency resources, things like food banks, soup kitchens, housing and utilities, and also really benefit from access to employment and education resources. Those are not things that most clinics have all in one place. So this is one of many, many reasons that it's so helpful to have positive and really consistent relationships with the organizations in our community who offer these services. We want the path from our clinic to these organizations to be as smooth and clear as possible, so that patients really feel that they're still being held in this net of care, even though they're seeing providers who are at a different agency. The therapist role on this team, this is because some degree of psychotherapy is recommended for all patients on buprenorphine, but I do want to be very, very clear, it is not mandatory, and we want to be very, very sure that therapy is never an obstacle to accessing medication, because in the past, sometimes that's how it has worked out. And we know so clearly, the research is unambiguous here, that medication is the key and the heart of making sure that these patients are as safe as possible and that they get a firm footing early in recovery. And then what therapy can do is address the many, many co-occurring conditions that usually go along with OUD. We rarely see it all on its own. So being able to address those other psychiatric comorbidities, including other substance use disorders. We see a whole lot of PTSD or experience of trauma in this population. Being able to address those issues as well as other psychosocial stressors to make sure that this patient is set up for a stable recovery when they have access to medication. We don't want it to be one size fits all, so the more versatile of a behavioral health team we're able to offer, the better. So typically this would include, cognitive behavioral therapy, some relapse prevention recovery planning, ideally contingency management. I know we're always working to open that up here in New Mexico. And then also integrated treatment for trauma and substance use, which, as I mentioned, that's a really common need for this population. Of course, when it works to have a behavioral health team working interdisciplinary with a medical team, that's ideal. But as we've talked about a lot in this echo, that just is not always realistic here in New Mexico. So again, having a consistent positive relationship with a behavioral health organization makes that referral much easier. With pharmacists, there's some interesting literature recently that kind of shows us that we've been, I think, underutilizing pharmacists in terms of how key they can be in turning the tide in the opioid epidemic. In addition to naloxone distribution, of course, they have a really important role for education, both for patients and also for providers, particularly around topics like chronic pain management. Another sort of unique aspect of their role is that they're really seeing the patients face to face on a regular basis. So they're in an unusual position where they're able to see early on and identify if there are non-reassuring patient behaviors and can communicate that to the team so that they can evaluate whether an intervention will be helpful to prevent further escalation of high-risk behaviors. In terms of advanced practice nurses, physician's assistants, midwives, MDs, obviously some very unique functions with these clinical roles. And also they're really important as a conduit for training and education to the rest of the team, to making sure that the team has access to the latest and most relevant research based on the population in the clinic. So this is sort of the abbreviated chart of who gets trained for what in this model. And you'll see that there are some sort of niche functions where one role is designated for a particular task. But then there's quite a few here where you see it says all staff, where things like basic understanding of addiction, handling challenging behaviors, addressing concerns about working with persons with addiction, that really needs to be bottom up, because we know that it's really important for patients to recognize that the clinic is anti-stigma, supportive, and welcoming, and that their first point of contact with the clinic can be really crucial in determining that, whether it's talking on the phone to a front desk person or chatting with the security personnel on their way in. If that's a positive and responsive interaction, then that sets them up for a more positive and more effective interaction with the team as a whole. So really important in terms of ensuring that we're creating that anti-stigma and welcoming environment. So the model that the team-based approach is drawn from is called the Massachusetts Collaborative Care Model. This was initiated, I think, at the Boston Medical Center around 2007. And the research continues to support that it's a very effective model, particularly in areas like ours, rural areas, where we're really trying to leverage the local capacity to the extent that we can. What they did here with the original model back in the dark days of data waiver, which thank goodness are behind us, was that they were able to increase the waivered physicians by 375% in 3 years, which is so remarkable. And a lot of that was through the robust education, training, and support program, which we'll talk about in a moment. Another accomplishment there was that it really increased the number of patients on MOUD, particularly minorities. And we know historically, as healthcare organizations, we have not done a great job of making treatment access very ready for these populations or following up with treatment engagement. In this study, nurse care managers, NCMs, were central to the process. You'll see in a moment, they're really kind of the linchpin of the day-to-day activities. And what they found here initially was that one nurse care manager could carry a caseload of 100 patients, and that if they were supplemented with a medical assistant who had been trained for this role, that they could carry a load of 125 patients. So obviously very impressive in this research when the model was implemented correctly. The staff felt happy about their work. They didn't feel overextended, and the patients felt satisfied with their services. So there were no gaps in service, even with that very high caseload. So obviously this was exciting in terms of producing a financially viable and sustainable model. This is just a graphic that represents, as we talked about earlier, what the Massachusetts Collaborative Care Model is based on, and that's that patient really right at the center, held within this kind of net of care of different individual providers and care providing organizations. So this is the patient flow in the office-based opioid treatment model, and you'll see the lion's share of those day-to-day tasks are carried by the nurse care manager, so you can see why they were so pivotal. So that includes the initial screening assessment. That is then reviewed by the whole team in a weekly chart review meeting to decide who's eligible for treatment. Next, the MD does those tasks that an MD does so well: the physical exam, the diagnosis, decision to prescribe. And then from there, you can see that the nurse care manager is actually in charge of the majority of subsequent tasks, but the MD is always there available and as backup. So that includes aspects like prescription generation, most facets of buprenorphine induction, such as assessing and educating patients on medication, support and titration during induction. and then even stabilization monitoring and maintenance with follow-up. So again, the MD is there, but the NCM is going to be the primary point of contact and the main one communicating with the patient. And that frees up the prescriber to be able to do what they uniquely are able to do. And the NCM can make sure that the patients are getting all of the support and information that they need. This is a slide for your reference that can show you the particulars of the screening assessment. And then as we move towards wrapping up, I want to make a point about the importance of training. So fortunately, we're in a totally different era now in terms of waiver training, but that doesn't mean that training itself is not still important. As I mentioned before, we really need that 101 kind of introductory training on addictions and buprenorphine for all staff, including just generally how to work with individuals with substance use disorders to ensure that patients are feeling welcomed into the clinic and that they want to come back and stay engaged in treatment. And then another part of this, and you'll recognize this as a key piece of the ECHO model, is providing ongoing trainings, shadowing opportunities, and clinical support, including telephone and email backup, so that providers really feel confident that when they're dipping their toes into this new model, that they're going to have plenty of support if they run into anything that they're not sure how to handle. And that includes being, staying up to date with the latest research. Another piece of this is making sure that we use a sort of open access model with policy and procedure manuals. We don't want clinics to have to spend time developing that when it's already been developed. It can be adapted or modified to different clinics. That's important that that's done. But we want to make sure that that infrastructure, including support on billing, is already in place so that staff is not expending any kind of resources on developing, on reinventing the wheel. This is another slide for your reference where you can see the topics that are covered in that office-based opioid treatment core training program. If you look at it closely, you'll notice there's a whole lot of overlap with what we're doing here on this MOUD ECHO, because the research has borne out that those are really the key pieces of making sure that clinics and prescribers feel ready for this model. And then I'll wrap up just to speak to the importance of clinic administrators in successfully implementing MOUD. What we know from the literature is that when this model does not work well, very often the staff will articulate that they feel the administration is not being fully supportive. Whereas when they have a really robust and well-informed administration, the model tends to go quite smoothly, even when it's adapted to very niche clinics. So some of the things that administrators can do in order to support the clinical team are just concretely to allow for regular meetings with open communication. So this is kind of just about healthy organizational culture, making sure that staff is able to provide feedback in a way that improves policy and functioning. Of course, again, with healthy organizational culture, that has to do with making sure that the clinic is adequately staffed. So in this model, there are really clear numbers about what caseloads work and about which members of the team need to be at what ratios. So it's really, really important that staff do not feel overextended or burnt out. And if the model is implemented correctly, then they will not. A key part here, going back to the importance of training, is making sure that time is available in the staff schedule for continuing education. We've talked a lot on this ECHO about how the landscape is constantly changing with this population, particularly with fentanyl. So we want to make sure that everyone has the best and the latest information. And then, of course, with the administrators working collaboratively with the team to create clinic policies and guidelines that reflect how it actually looks on the ground. So last thing I'll say is just a reminder of things you can do right now. Being an advocate for your patients, if you're here, then you're probably already doing that. Making sure that you're creating an accepting and patient-centered and anti-stigma environment that keeps patients engaged. And then working with whatever level of leadership you have access to enact policies that are going to support this community. And policies sound abstract, but they really do change lives and with this population, save lives. So some of those could be, for example, funding for treatment, drug take-back programs, education specifically designed for community members, and then very importantly, and it's a tough one, is youth engagement, because that's really how we're going to change that paradigm moving forward. So I'll move to questions now. I'll stop sharing so I can take a look at the chat.